Hello everyone. At the outset, I would like to thank the members of the organizing committee for giving me this opportunity to present the topic. I am Narendranath Epperla from the Huntsman Cancer Institute at the University of Utah, and I am delighted to present the ASTCT clinical practice recommendations for transplantation and cellular therapies in diffuse large B-cell lymphoma. These are my disclosures. Autologous hematopoietic cell transplantation has long been the standard approach for patients with relapsed or refractory chemosensitive diffuse large B-cell lymphoma. However, the advent of CAR T-cell therapy has caused a paradigm shift in the management of relapsed refractory DLBCL patients, especially with the recent approval of CD19-directed CAR T-cell therapies in the second-line setting in high-risk groups, that is, primary refractory and early relapse DLBCL. Allogeneic transplantation is another potentially curative option in relapsed or refractory DLBCL that can provide durable disease control even after autologous transplant relapse, with a therapeutic mechanism attributed mainly to the graft versus lymphoma effect. The use of reduced intensity conditioning with allogeneic transplantation has significantly expanded the access to allogeneic transplantation across the world. However, similar to autologous transplantation, the advent of CAR T-cell therapy has led to a recent decline in allogeneic transplantations, effectively relegating allos for patients whose DLBCL progresses after CAR T-cell therapy. Consensus on the contemporary role, optimal timing, and sequencing of transplantation and cellular therapies in DLBCL is lacking. Hence, the ASTCT undertook this project to formulate consensus recommendations to address this unmet need. We used RAND modified Delphi methodology, which was used to generate consensus statements addressing the sequencing, timing, and role of transplantation and CAR T-cell therapies in patients with both newly diagnosed and relapsed refractory DLBCL. In the Delphi method, participants rate the statements anonymously in generally 2 rounds of voting. In the modified version of the method, a face-to-face meeting with the presentation of the results precedes the second round of voting if needed. Just to give you a snapshot of the various steps, as an initial step, a panel is selected, and for this project, there were 25 physicians that were selected, including 7 members of the steering committee and a methodological expert with expertise in systematic reviews, meta-analysis, and the RAND modified Delphi method. After that, a survey was sent to understand the baseline demographics and scope of the project, which led to the creation of the consensus statements. These consensus statements were then circulated to the panel members, and they provided their voting. A formal consensus were to be achieved if 75% or higher of the panel members voted to agree on the particular consensus statement. If a formal consensus was not achieved, then a second voting survey would be done. Grading of recommendations was based on the Agency of Healthcare Research and Quality, AHRQ in short, based on the level of evidence. Grade A stands for if there is good research-based evidence to support the recommendation. Grade B, when there is fair research-based evidence to support the recommendation. Grade C, the recommendation is based on expert opinion and panel consensus. And grade X, if there is evidence of harm from this intervention. The consensus statements for transplantation and CAR-T treatments in DLBCL were broadly categorized into three groups. After first-line chemoimmunotherapy, in primary refractory and early relapse DLBCL, and late relapse DLBCL. Let's go one by one. First, we'll talk about the consensus statements for transplantation and CAR-T following first-line chemoimmunotherapy in DLBCL. This table and all the subsequent tables will have the same format, has three columns. The first column outlines the consensus statements. The second column outlines the grading of recommendation based on the AHRQ guidelines that we just discussed a moment ago. And the third column depicts the percentage of panelists in agreement. Just to remind the audience, a formal consensus were to be achieved if 75% or higher of the panelists were in agreement. Let's go on to the statements one by one. The panel does not recommend autologous transplantation in DLBCL regardless of the International Prognostic Index score as consolidation in complete remission after first line, that is R-CHOP or similar therapy. The panel does not recommend autologous transplantation in high-grade B-cell lymphoma with MYC, BCL2 and or BCL6 rearrangements as consolidation therapy in PET negative complete remission after dose adjusted R-EPOCH or similar high intensity regimens. Autologous transplantation may be considered in eligible patients with high-grade B-cell lymphoma with MYC, BCL2 and or BCL6 rearrangement as a consolidation therapy in PET negative complete remission after first-line R-CHOP or similar therapy. This is based in part on findings from the retrospective analysis by Lensberg and colleagues suggesting that autologous transplantation as a consolidation can provide a benefit in patients treated with R-CHOP, but not in patients receiving more intensive induction therapies should they achieve CR. The panel does not recommend CAR T-cell therapy in the frontline setting for high-risk DLBCL regardless of the IPI score or presence of MYC, BCL2 or BCL6 gene rearrangements outside the setting of a clinical trial currently. Autologous transplantation may be considered for eligible patients with DLBCL with secondary CNS involvement at diagnosis, achieving complete remission and with undetectable CNS disease after first-line therapy. It is important to acknowledge that this is a data-free area of clinical practice and that this recommendation reflects the expert opinion of panel members as noted by the grading of recommendation of C. The panel recommends consolidation with autologous transplantation for eligible primary central nervous system lymphoma patients in first complete remission. The panel recommends thiotepa-based conditioning regimens when using autologous transplantation as a consolidation for eligible primary CNS lymphoma patients in first complete remission. Let's move on to the second broad category of consensus statements for transplantation and CAR T treatments in primary refractory and early relapse DLBCL. Of note, the early relapse is defined as relapse within 12 months of first-line chemoimmunotherapy. The panel recommends CAR T-cell therapy as standard of care option in patients with DLBCL who have refractory disease to first-line chemoimmunotherapy or have relapsed within 12 months of first-line chemoimmunotherapy. This is based on the high-level data from 2 phase 3 randomized trials that showed superior event-free survival, and more recently, one of the trials showed overall survival benefit on long-term follow-up in patients with primary refractory and early relapse DLBCL receiving CAR T therapy compared to standard of care salvage therapy. For DLBCL patients with early treatment failure but established disease responsiveness to salvage treatments, careful consideration of the pros and cons of CAR T-cell therapy versus autologous transplantation as a consolidation is warranted. It has been previously shown that patients achieving chemoresponsive disease to salvage therapy may experience durable remission following autologous transplantation, including those with early chemoimmunotherapy failure. In studies comparing standard salvage chemotherapy with autologous transplantation versus CAR T-cell therapy in the second-line setting in the phase 3 randomized trials in relapsed refractory DLBCL, only a small portion of patients in the standard of care arm underwent autologous transplantation compared to those who received CAR T-cell therapy in the experimental arm. In addition, the data on chemosensitivity prior to autologous transplantation was reported only in one study, that was Belinda, wherein 31% of patients achieved chemosensitivity prior to autologous transplantation. Although CAR T-cell therapy provides superior outcomes relative to standard salvage therapy in the second-line setting, the most appropriate strategy, that is, autologous transplantation versus CAR T-cell therapy in patients with relapsed refractory DLBCL achieving chemosensitivity, was not determined in these trials. In a recent CIBMTR analysis by Shadman and colleagues, the authors found that autologous transplantation was associated with a lower incidence of relapse and superior overall survival compared with CAR T-cell therapy in patients achieving a partial remission after salvage therapy. Of note, this was not an intention to treat analysis, but rather an analysis of patients who had infused cells. And the authors acknowledged this as a potential reporting bias, rightfully. Keeping this data in perspective, for patients with relapsed or refractory DLBCL achieving chemo-responsive disease, that is either CR or PR, to salvage therapy, the panel considers autologous transplantation as an acceptable therapeutic option in eligible patients as depicted by grade B, which is the consensus statements 2 and 3 on the table. In DLBCL patients with early relapse who achieve a complete remission or partial remission to salvage therapy, the panel considers CAR T therapy as an acceptable therapeutic option. Moving on to the last broad category of consensus statements for transplantation and CAR T treatments for late relapse DLBCL. Again, late relapse is defined as relapse beyond 12 months of first-line chemoimmunotherapy. In DLBCL patients, the standard of care in the relapsed or refractory setting has been autologous transplantation in those who achieved a chemoresponsive state, either CR or PR, based on the results of the pivotal PARMA study that compared autologous transplantation with further cycles of salvage chemotherapy in patients achieving a response after the initial salvage attempt. These results were further corroborated in the rituximab era in the CORAL study. Furthermore, patients who achieve a CR to salvage therapy, especially those with a negative post-salvage PET, that is PET CR, have the best outcomes after autologous transplantation. That is 3-year PFS of over 80% with PET CR versus less than or equal to 35% with positive PET. These data underscore the role of autologous transplantation as a consolidation in relapsed or refractory DLBCL patients achieving a response, either CR or PR, to salvage therapy. Hence, based on this data, in DLBCL patients with late relapse, the panel recommends autologous transplantation as a consolidation therapy in eligible patients who have achieved a complete or partial remission after second-line therapy. In the SCHOLAR-1 study, the CR rate was 7% and the median overall survival was 6.3 months with the use of existing therapies in patients who had aggressive B-cell non-Hodgkin lymphoma that was resistant to chemotherapy or who experienced a relapse within 12 months after autologous transplantation. In contrast, results from 3 single-arm phase 2 pivotal CAR-T trials, ZUMA-1, Juliet, and Transcend, which established its utility in patients with multiply relapsed DLBCL, showed relatively better outcomes with CAR T-cell therapy in these settings. All 3 CAR T-cell products demonstrated the ability to induce durable remissions in approximately 1/3 of treated patients, including those not achieving a durable remission with a prior autologous transplantation, thereby receiving US FDA approval for treating relapsed or refractory DLBCL patients after at least 2 prior lines of therapy. The recently published 5-year follow-up analysis of ZUMA-1 continues to demonstrate sustained overall survival and disease-specific survival in these patients. Hence, based on this data, in DLBCL patients with late relapse, the panel recommends CAR T-cell therapy in patients who have not achieved remission, that is, have not achieved either CR or PR to second-line therapies. In patients with DLBCL, the panel recommends CAR T-cell therapy in patients who are not eligible for autologous transplantations due to comorbidities or age, regardless of the timing of relapse. In patients with DLBCL, the panel recommends CAR T-cell therapy who have relapsed or refractory after 2 or more lines of systemic therapy. The panel does not consider secondary CNS involvement as a contraindication for administering CAR T-cell therapy. In relapsed DLBCL patients with available access to CAR T-cell therapy, the panel recommends offering CAR T-cell therapy before proceeding with allogeneic transplantation. Allogeneic transplantation may be necessary for patients who relapse after CAR T-cell therapy, given that allogeneic transplant can be potentially curative following failure of autologous transplant, especially in patients who achieve chemosensitivity. In the EBMT analysis of a little over 500 patients with DLBCL who relapsed after autologous transplantation and underwent subsequent allogeneic transplantation, 31% were able to achieve long-term PFS at 3 years. In a recent multi-center retrospective study of allogeneic transplantation following CAR T failure, the 1-year PFS and OS rates were 45% and 59% respectively. In both these studies, the single factor associated with superior outcomes was achieving chemosensitivity at the time of allogeneic transplantation. Hence, the panel recommends allogeneic transplantation in eligible DLBCL patients relapsing or progressing after CAR T-cell therapy if they achieve a complete or partial remission with subsequent anti-lymphoma therapies. The panel recommends allogeneic transplantation eligible relapsed or refractory DLBCL patients after autologous transplantation failure in regions without access to CAR T-cell therapy and in those with CAR T-cell manufacturing failure, ideally after achieving a complete or partial remission with subsequent anti-lymphoma therapies. The panel recommends reduced intensity conditioning or non-myeloablative conditioning regimens for eligible patients undergoing allogeneic transplantation. In clinical scenarios where data from prospective studies are either scarce or unavailable, or in situations in which patient populations included in the published trials are less relevant to contemporary clinical practice, formal consensus recommendations can be invaluable resource to inform clinical decision making. The advent of bispecific antibodies will imminently further change the therapeutic landscape of relapsed refractory DLBCL. CAR T and bispecific antibody therapies are now being studied in the first-line treatment, and treatment algorithms will continue to evolve as data emerges from these studies. So stay tuned for additional changes in the coming years. I would like to thank everyone for their undivided attention and would like to acknowledge the Committee on Practice Guidelines, Dr. Carpenter and Dr. Hamadani, the steering committee members, Dr. Suter, Dr. Miguel Perales, Dr. Kharfan Dabaja, and Dr. Locke, expert statistician, Dr. Kumar, and all the panel members outlined on this slide. Thank you.